Thank you, Hilary, for those kind words. Good afternoon, colleagues, ladies and gentlemen. The whole idea of giving this short talk on my journey through reconstructive urology and the lower urinary tract reconstruction, which includes bladder and urethra, I'll confine myself to the bladder reconstruction. The glimpse of my journey over these 25 years, since 1995, I just want to tell you that if I can do it, you can do it. So, and you can do it in a better way. Because when we started our journey in this subject, the help and support from any aspect was minimal. There were no social media support that much, there were no videos, and mentorship was not there. We have to go for special training courses, we had to find it, and the whole subject was in its infancy. Just a bit. Enter, right. When would one lose the bladder? So there are many indications, as we all know, we all come across. When I started my career as a young urologist, these indications were already there in the world. But the problem was that most of the time, the cystectomy was kind of a nightmare for urologists and surgeons. Removing a kidney was simple, but removing a bladder was a challenge. So because of that, most of these diseases I have listed down there were tackled in more conservative manner, but with a lot of burden and a lot of morbidity and mortality to the patient. And bladder cancers were there, and muscle-invasive bladder cancer, and chronic inflammatory disease like benign disease like tubercular cystitis with contracted thimble bladders, radiation cystitis with bleeding. They were all there, but they were managed conservatively with the poor outcome. And neuropathic bladders were managed in a worse manner a couple of decades back when we started. With upper motor neuron bladders, with all contracted, high-pressure bladders with upper tract destruction. Bladder was a mystery organ. And we, apart from these common indications, still have actually, a very unique collection, unique cohort of patients we came across. They were all referred, just going through word by mouth actually. These were the people with failed childhood bladder exstrophy repairs. As you know, bladder exstrophy, we see about 8 to 10 children, considering the statistics there, 354,000 childbirths. Even if you take it as 2 per 100,000 live births, we came across lots of ectopia vesicis. These people were repaired at the Lady Ridgeway Hospital or the Children's Hospital at the beginning, but the first day repair or early repair, as they advise now, so within 6 months, did not take place. So because of that, they came late, and the repair was suboptimal, and throughout life, until they were sent out of the Children's Hospital, they were suffering with either the bladder exstrophy has recurred, or they are completely incontinent. And they have become social outcasts, and they were not accepted by the schools or the rest of the family even. So this is the group, the unique group, and repairing of their bladders, which will give me a peaceful sleep for the rest of my life. So the people who we have followed, the numbers are more, but the people who we could follow and collect, I have mentioned here. And we have presented it in 2019 in EAU 19, our outcome of repairing these bladders and replacing these bladders. Urinary diversion is defined as you know, alteration of lower urinary tract from its natural path. Before 1995 in Sri Lanka, cystectomy and urinary diversion were rarely done because the main indication was muscle invasive bladder cancer. And bladder cancers were treated mostly with transurethral resection, radiotherapy, and some kind of chemotherapy. Because what happened was that we cut whatever we see on those bladders, and then we send them to Cancer Institute, and we hardly ever see them again. Because my 2-year senior surgical registrar training, I have done lots of clinic work, and those clinics, they don't come back. Say they either are followed up there at Cancer Institute for the rest of their life, or they have perished. So, I mean, it is natural. It was natural for us to expect that for them to come back with some kind of at least complication like hemorrhagic cystitis or contracted bladder. Hardly anybody came back. So that was either the haven of cure, or it would have been their graveyard there. So that of course disheartened us, because when we went through our statistics, world statistics, that shouldn't have been the case. So cystoplasty for a contracted bladder or non-functional bladder was even more rare in 1995 because those were all carrying catheters, because they are more or less nearly incapacitated by very high frequency or incontinence. So they were just put an indwelling catheter and they were sent home, so just on catheter. Sometimes young people, most of the occasion young people. An occasional diversion method, when the cystectomy became, cystectomy rarely done, the diversion methods which were used, especially in children at the Ledridge way, was ureterosigmoidostomy, and ileal conduit was also a rare thing. Continent diversion was unheard in 1995 and before 1995. It was unheard in Sri Lanka, but when we were senior registrars, we used to read about it. And bladder reconstruction. These are the numbers I could collect because I have been maintaining my personal notes. And since 1995, there are many more which we can't follow because the dropout rate is very high in this situation. Radical cystectomies, the neobladders, we have made new bladders in a certain number of people, and you will see that still the ileal conduit diversion is the commonest way of urinary diversion after removing a bladder. This is the case in rest of the world as well, because the urostomy care has become so standardized and improved that still urostomy is playing a role, and for even benign conditions it's the same. Then the quest for continent diversion was always there, because incontinent diversion by urostomy was cumbersome to the patient, and especially in the Asian countries. Carrying a bag full of urine is a difficult task. So just a glimpse of history. It has been there. The attempts have been there since 1852 by Simon, just diverting ureters into the sigmoid colon, and Coffey, who popularized the technique, and the rectal sphincter was taken as the urethral sphincter. But there were a lot of problems, because we could see that children who have undergone ureterosigmoidostomies, when they became adults and came to our clinics on and off, they were all having a lot of metabolic problems like hyperchloremic acidosis and recurrent urinary infection, upper tract infection leading to shrunken, contracted, scarred bladders, and they are in renal failure. They were in renal failure. So actually, because there was no transplant program in this particular era, I mean, we have signed their death certificate. And just before moving from ureterosigmoidostomy, we have modified, in our series, we have modified this technique in few patients, I think, who have flatly refused to have a bag or a urostomy. Those people, there are some living examples still coming to the ward. I'm sure my junior colleagues would have met them. We use this same principle of ureterosigmoidostomy, but we make a rectosigmoid pouch, joining the rectum and the sigmoid colon together and making an in situ pouch to prevent urine getting dispersed along the colon. Biggest problem is that once urine is diverted into colon, as you know, it will get absorbed. Colon's job is to absorb, and 6 feet of colon will start absorbing urine. So to prevent that, we use this modified technique. This is not our technique, but this is a standard technique, a rectosigmoidal sigma pouch, which is a useful variation of uterosigmoidostomy, which can be used by you all. Then again, incontinent diversion, as I was mentioning, has become very popular because the complication rates are low, and we also still use it in majority of our urinary diversion techniques. And it is the commonest form still worldwide, and technically simple and reliable. I'm sure most of my colleagues will, with closed eyes, will make a good urostomy. And all new methods are still compared with the outcome of ileal conduits. Few technical details, I think, which I'm sure most of you all are familiar, are that we use we make a very good external stoma. That is the key to success, because if it becomes like a colostomy, flat with the skin, it is a disaster, because you can't wear a bag. So this Brooks rosebud technique we use very frequently. And the reimplantation into the conduit, as you know, there are two main techniques. My preferred and our unit, the preferred method is Wallace technique, which has a wider anastomosis with the ileum and lesser degree of ureteric stenosis. The Bricker's technique has a higher chance of ureteroileal anastomotic strictures. But on the long run, the large studies, the large-scale studies have shown that ultimately, though they have their own problems, these Bricker and Wallace, the final outcome is going to be more or less same. But what are the problems we encountered in ileal conduit? Making ileal conduit is simple, but then if you go to a reconstructive urology clinic, you will find these problems coming up. The worst nightmare, you can see far end of this slide, coming for the morning round and suddenly see your ileal conduit looks like that is a disaster, because what you have done is that the pedicle has been knocked out and you have to refashion it. But on the other hand, in the long run, you will come across this urostomy prolapse and dermatitis, and still our clinics, there are a couple of people who will be hanging around with these large parastomal hernias. The bowel has just crept around the ileostomy with a weaker abdominal wall, who are waiting repair. Then again, because of all these problems of ileal conduit, we were very strongly thinking of finding a way to get rid of the urostomy bags. So then, after, as you can see in the history, the timeline, these neobladders, the new bladders have been there since 1962, just after I was born. So, it came to Sri Lanka in 1998 when we made the first neobladder, and it was introduced as a regular feature of urological armamentarium since then. It has been the most attractive cosmetic diversion, and low pressure, the whole idea is to make a low pressure reservoir, and urethral sphincter, if it is there, you use it for continence, but if it is not there, you make a catheterizable stoma. That is the principle. And the only drawback are that it's long operating hours, and you need some sort of specialized training, in the sense that some sort of a mentorship or study in the at least seeing few things, which we never had the opportunity, but my junior colleagues will always have that opportunity. But sphincter mechanism preservation during cystectomy, cystoprostatectomy, is essential if you are planning for a neobladder. So basic surgical principles, just 1 minute of your valuable time. We generally go for either orthotopic neobladder, which is connected to the urethra. So the conduit will be the intact urethra with the sphincters, while continent mechanism will be the sphincters again. But on the other hand, if you have lost the sphincter or lost the urethra at all completely, then of course you go for a neobladder. Some people call it heterotrophic neobladder, but it's not a very appropriate term. It's best called a neobladder with continent catheterizable stoma. Urethra is no longer there, so you have to use some kind of a tube to do self-catheterization. Our preferred method will be the using the intact appendix, but as you know, in some people the appendix may not be there, in which case we use Yang-Monty and tapered ileum as catheterizable conduits. When I started my life there, reconstructive urology life, my preferred neobladder was CAMI. CAMI 1 was done long time ago, and CAMI himself gave it up because that was a U-shaped tube, very easy to make. You take a long piece of ileum and then just connect ureters to one end, then the other end is closed and it is connected to the urethra. But what CAMI himself has found was that this is a very low capacity bladder and which can generate high pressures. So because of that, the principle of tubularization, or opening the bowel and making it into a composite compartment was introduced, and this CAMI 2 it was the neobladder at the beginning of our career. And I still prefer that technique, except that because it's kind of a low capacity bladder, the incontinence rates were pretty high. But then the modification came in later on in our journey, and that is the Studer pouch, which was introduced some years back, and then now it has become the standard neobladder formation. It's actually a modification of CAMI, and then it's easy to convert yourself if you are used to it. Only difference will be that one arm is long and it's called the chimney, and the chimney is connected with ureters, and there is a slight difference from CAMI that you, once you have made the detubularized chamber, you bring the far end to the two ends together to make the pouch look globular, and it looks just like a bladder. So that gives a better capacity and better function, and what they have found is that has become now actually the standard method of neobladder in most of the places. The other neobladders which I have not tried, available for the future reconstructive urologists, are these Hotman and the Mansoura pouch, which are very popular, but they use longer segments of ileum, so and it takes a little longer time, and the anti-reflux mechanisms are different, but those are all technical. But those two methods are also time tested, and you can use if you need a larger bladder. Then the second group of people who didn't have the urethra and the sphincter, they need this neobladder with self-catheterization. The mains pouch was the first ever pouch we made, and the first main pouch was made in around 1999. And our preferred segment of bladder, the bowel, was ileocecal segment. But at that time, it was the popular segment because it was close to the urethra and it was easy to make. So this is called mains 1 pouch, and we have done a fair number of that. But later on, the colonic pouches went out of favor, and then because of that, we have moved now into Studer pouch or small intestinal pouches. And the catheterizable stoma is made up of made from the appendix. So first thing when we open up and before doing the cystectomy, we look at the appendix. But if the appendix is short and it has undergone chronic inflammation and atrophy, then of course we have to use either this Yang-Monty, which I have not used very frequently because there are too many anastomoses, or what we use is a tapered ileum. So Skinner's tea pouch is also popular among some of my colleagues later in our journey, and but I have never tried that. So ileocecal pouch and the appendix or Yang-Monty is the standard. And the other reservoirs we have used on and off, but I think the numbers wise very less, but you can use it because we have to have all these methods up in your sleeve if you are doing the reconstruction, bladder reconstructions, because when you open up, you don't know what you are going to face. So to save time of attaching the ileum to the cecum, what you can do is just use the cecum or ascending colon and detuberarize it, and then you can make this pen pouch and the Indiana pouch. You don't involve the ileum in those, and then you can use again, as shown here, the tapered ileum with inkwelling of the distal part into the cecum, or you can detach it completely and bury it in a submucosal tunnel of tinea. So these two pouches are available for you all because I have tried it off and on and it works. But stick to one type when you start doing it because that becomes better and better in your hands. Last part of this is that when we start doing these things, always it sort of put a question mark in our mind. Are we actually we are going against the stream, upstream, and then is there any evidence? Because the whole world is moving towards evidence-based. So are there any evidence to show that what we are doing is better than what the predecessors did? So there are few things here. You don't have to worry about these crowded slides, but basically, quality of life. Is it different, urostomy versus orthotopic neobladders? And there are some nice meta-analyses. One is done by Eva Brown and published involving many papers and over 45,000 people. And final outcome, final conclusion was that there is no significant increase in morbidity with orthotopic neobladder compared with ileal conduit. And also there is another study to show that neobladder patients are more likely to have better global health status. But putting aside all this evidence of these, not having a bag on a patient who has no money to buy a bag, the bag keeps on falling from his skin because he is sweating a lot, it doesn't get attached to the skin, and sometimes non-availability, non-affordability. All these things if you consider, even if this evidence is not there, giving a neobladder will be a blessing for him. Few more evidence to show that which segment is better, because there has been an argument to find out whether it's ileal segments or the large bowel segments are better. Because world is moving towards small bowel segments nowadays, but if you go through some evidence, they have their own problems. So ileal neobladder has been always favorable, it has come out with favorable patient satisfaction. Sigmoid neobladder gives a bigger bladder and longer hours of continence. Does the type of reservoir matter? Whether you are going to make a pen pouch or Struder pouch or cami, does it make any difference? Actually, this large systemic review done by Michael Rank, it's a nice summary. What it says is ultimately what is best in your hand is what you have been practicing. So if you analyze, do a meta-analysis, there is hardly any difference between the outcomes of each and every neobladder. Finally, I think this neobladder is not, everything is not hunky-dory, and once you make a neobladder, patient will not live happily ever after. They will become part of the furniture in your clinic, and they will become part of your life. So, I mean, you can't leave them. If you are leaving, you have to hand it over to your successor to look after them, because this is lifelong follow-up. Because they have survived the cancer, but they have not survived the great big constructive surgery we have done. So we have changed the God's plans of anatomy so that we have to take the responsibility. And the complications we see in the clinic, and sometimes they come to the private sector, many of them because they come only twice a year. So febrile UTIs and urethral strictures and hydronephrosis and anastomotic leaks at the beginning. And the metabolic consequences are much less if they regularly empty their bladder, either by using the abdominal pressure or by self-catheterization or through the urethra or the catheterizable stoma. They're doing it properly, but you have to keep an eye on them to see whether they are doing it well by doing ultrasound with pre and post void volumes. And rare complications have been there, but none of them I think we have come across. Only dreaded complications which I am having nightmares about is getting adenocarcinomas in these neobladders. And looking at my junior colleagues here, I think they are going to take the responsibility of them. So because they will come during their lifetime. So because adenocarcinomas come long time after these diversion methods. So keep an eye on those things and treat them like just any other cancer. Important thing is to pick them up early. And cutaneous stomas also not devoid of complications. Basically, Mitrofanovs. If you make Mitrofanov diversion with appendico-neovesicostomy, main problem is that the valvular mechanism, if you don't do it properly, it will start leaking again. The whole purpose of making a catheterizable stoma to make the patient dry will go down the drain. So you have to, if you wait for a while and then you do test, you fill up the neobladder and see whether they are leaking. If they do, and once you have confirmed it, straight away go for refashioning it. And then neobladder stones are also a problem, and if you follow them long enough, after 5 to 10 years, because of the stagnation and poor catheterizable methods, they will have these neobladder stones. And earlier it was a dreaded complication because we have to open up the neobladder, and then sometimes they end up in cutaneous fistulae. So we have adapted this technique in our unit of managing these neobladders with a similar technique to PCNL. Because what we do is we just do a percutaneous puncture into the neobladder and then dilate the tract, cutaneous tract, and then crush the stones. It's a little more difficult than PCNL where the space inside the kidney is very small, but here you are like chasing rabbits. You have to chase behind all the stones and you can take them out completely. And if you try to go through the Mitrofanov and try to crush these large stones, sometimes you will destroy the Mitrofanov or catheterizable trauma and its sphincter mechanism. So why this percutaneous method is much better than trying to tackle these large stones through the stoma. Final word of caution. This is the last slide. So I can see a lot of relief in your face. Sorry if I've taken too much of time. And don't operate on these people, okay? So don't make any kind of neobladders or catheterizable stoma because you won't know where the stoma is after you have made it. Next day you will find the stoma is close to the knees. So it will be extremely difficult. So body habitus, you have to be careful when you are thinking of making neobladders. And poor renal function and poor liver function is not an absolute contraindication, but if it is marginal, it's all right. But if the serious renal function deterioration, be careful in making intestinal bladders because that the urine is going to get absorbed and that's going to give trouble. And so EGFR, if it is less than 35 or 40, try to just do a ileal conduit and come out. And that is the most important contraindication. And irradiated and short bowels, if that area is irradiated previously and the bowel is all gone, they are endarteritis and they are shrunken, you have no segment to take it. And some people have tried to take upper colonic segments, but rather than doing that, just go for a simple ileal conduit. And poor manual dexterity is also important. patient may be, his soul may be strong, but flesh is failing. And for them, if they can't catheterize this properly, either through the urethra or the neobladder, try your best to avoid it. Finally, take-home message is that the world is moving towards neobladders and continent diversion. You can see these graphs there. Number of ileal conduits are coming down now, especially if the facility is available and the specialized centers are there to refer, or people who have taken up it, then this trend will be projected to our setup as well. So you can see, and new technology is also creeping in. At the moment we are doing all open surgery, but the same thing, there's a trick of robotic surgery and laparoscopic surgery. If you can do it with open surgery, you can do it through the keyholes as well. So laparoscopic robotic assisted neobladders are coming up, and once we have the robot, we will convert our techniques into laparoscopic and robotic techniques. Thank you very much for your patient listening.